Okay, so the first thing you want to talk about in diabetes is something called the diagnostic criteria. How do you diagnose diabetes? And this diagnostic criteria is the same whether you have type 1 or type 2 diabetes. The first thing, if you have a random blood glucose of greater than 200, plus you have symptoms, okay, that in itself is enough. Or you can have an HbA1c of greater than 6.5, and that's good. If you have a fasting blood glucose of greater than 126, that is diabetes only if it happens twice. And the last thing is if you do a glucose challenge test. So in the glucose challenge test, what you will do is you will give 75 grams of glucose and you will measure the glucose 2 hours later. If the 2-hour glucose is greater than 200, then you have diabetes again only if it happens twice. So that's how you diagnose diabetes. So we'll take a look at diabetes 1, DM1. Okay, the person with DM1 is young, and it is usually a genetic condition, in which case you get the anti-islet antibodies, or you get the anti-GAD antibodies. Remember, in diabetes 1, you have no insulin, and your whole problem is solved when you give insulin. So the treatment is give insulin. Very simple. The thing that can happen with DM1 though is that you can have something called diabetic ketoacidosis. So what happens in diabetic ketoacidosis? Well, let's say you have this one cell here, okay? So that's your cell, and this is your blood vessel. You have, this is all your glucose, and the glucose is going in. But this process itself is inhibited because you have no insulin, right? So this does not happen when you don't have any insulin. So what does the cell do? Well, you have other things in your bloodstream, which are known as your triglycerides. And instead of using the glucose, your cell is going to take triglycerides. Now, note that when the cell metabolizes triglycerides, it's going to give out ketones. And the ketones are negatively charged. So what happens is, to balance this negative charge, you have to increase your H+, and you have to decrease your HCO3. Okay, so what is diabetic ketoacidosis? Well, it is increasing ketones, and it is acidosis, and it is, so if you remember the anion gap formula, the anion gap is equal to the Na minus the chlorine minus the bicarb. If you decrease this, you will have a high anion gap. And so diabetes, we call this a high anion gap metabolic acidosis. What are the tests you can do for this? So you get a serum HCO3. Also, you'll find that you can get an increased acetone, which is a type of ketone, or you can get an increase in beta hydroxybutyrate. And all of this will give you an indication that this patient has diabetic ketoacidosis. And so really we're going to talk about diabetes 1. Next we come to diabetes 2, or DM2. The person who has DM2 is essentially obese and older. And initially, at least, you have to remember that a DM2 patient has increase in insulin, but is insensitive to it, right? So the treatment for DM2 is lifestyle, diet, you can add metformin, you can add other drugs, and then finally it's insulin. And this is covered in our other video on the diabetes medications. If not treated right, DM2 is going to lead to HOHS, okay, or hyperosmotic hyperketotic state. So what happens in here? You have a cell, like you did, and you have the nuclei. Now you have one blood vessel and another blood vessel. Okay. Just like in diabetes 1, there's a lot of glucose in your blood vessel, and normally the glucose is supposed to be taken up by the cell. But this process is not happening because you have insulin insensitivity. You have insulin, but it's just not sensitive. On the other side, of course, you have your triglycerides. And when this fails, the cell is supposed to take in some triglycerides. Okay? The thing is that because you have high insulin, this actually decreases the lipoprotein lipase. And a decrease in the lipoprotein lipase stops this process as well. Because now, the cell cannot take up glucose, they cannot take up the triglycerides. Essentially, your cell is starving. But so you realize that there's no triglycerides, so therefore there is no acidosis here. And there is a normal bicarb because it doesn't have to do this balancing of the ketones because there is no ketones. Okay? So what would you do if you predict that somebody is in HOHS? You would get a serum osmolality, a serum sodium, you can get a urine osm and a urine sodium. Okay. Okay, the other problem that you have here that happens is that since your triglycerides and your glucose are not being taken up into the cells, these two are going to stay in the blood. If they stay in the blood, that's what gives you the increased serum osmolality. The increased serum osmolality then pulls water out of cells. Essentially, it even not just starves your cells, it even makes your cells thirsty. It pulls water out. Increased water in your bloodstream leads to an increased urine output. And this increased urine output again goes back and increases your serum osmolality. And that's why the test you get is a serum osmolality. Here you get a serum bicarb because it is increasing bicarb. Here you get a serum osmolality because these things stay in the blood and increase your serum osmolality. Make sense? Okay. The treatment is the same for both of them. Whether you have DKA or you have HOHS, the treatment is fluids, it's insulin, and it is potassium. So, fluids are going to resolve your dehydration. Insulin, why do you need insulin? It increases the glucose into cells. And yes, even if you are insulin insensitive, if you increase the insulin, it will make at least a little bit of glucose go into the cell. Okay? But remember, this requires the Na glucotransport, which will then cause hypokalemia because the Na going in and then the K will be kicked out. And so in the blood, you'll get a serum hypokalemia, and therefore you have to give the potassium. Okay. The other thing that we talk about really from diabetes standpoint are the complications. So these are the DM complications. Okay. What does diabetes cause? And we're really talking about diabetes 2. The first thing that diabetes 2 does is hyaline arteriosclerosis. It takes your little artery here, and it creates a plaque. It thickens the wall of the artery. Also, it creates puncture holes in the artery. Punctures in the hole of the artery. So, as with anything, if you decrease the space that it can go in, this is going to cause you hypertension. This is also going to cause you retinopathy. And because one of the other things that it does is not just decrease the gaps, it also decreases nitric oxide so that your vessels cannot expand. And if you decrease nitric oxide, you're going to cause erectile dysfunction. So if a patient with diabetes comes to you and has this, for the hypertension, you're going to keep a BP goal of less than 140/90, because he's more prone to get hypertension. If they have retinopathy, you're going to laser. And if they have erectile dysfunction, you're going to give them sildenafil or Viagra. Second thing that happens in diabetes, as I mentioned, is you have very high levels of insulin, at least initially. And these high levels of insulin go and decrease your lipoprotein lipase levels. So you have all this blood, and you have this cell over here. Usually the cell is able to take these triglycerides in, but because of no LPL, this process is not going to happen. And so what you're going to end up in your bloodstream is that you're going to have a very high triglyceride level. And because triglycerides cannot be broken down, then you're going to have a very low HDL level. And the treatment for both of these is statins, and you can give some of the other cholesterol modifying agents. The third thing that diabetes will do is that it will give you nerve damage. This is because you have your little sensitive neuron here, and this is the blood vessel that's running through it. Okay? Normally, you have your oxygen, but because of the thickening of the walls, there is no O2 left here. And so the cell actually, because there's no O2 left here, the cell actually starts dying. And this causes the death of the cell, which is going to manifest as 1, a stocking glove pattern of neuropathy. So this is starting from your feet, and it's also sometimes called ascending neuropathy. Starts from the feet all the way up. The second thing it can cause is autonomic instability, because it destroys the nerves that sense your heart to your brain and the brain to the heart. And the last thing that it can cause is gastroparesis. Again, for the same reason. So if you have any of these, if you have any nerve damage, what you can do is you can treat it with a TCA, or you can give gabapentin, or you can give pregabalin. If you specifically have gastroparesis, in addition to this, you will add metoclopramide, or you can add erythromycin. Because erythromycin, in addition to being an antibiotic, will help with the gastroparesis. And that's it. That's diabetes. Thank you for tuning in.